You are listening to the Journal of Rheumatology's Editor's Picks with Dr. Earl Silverman, Editor-in-Chief.
Hello again, this is Earl Silverman, Editor-in-Chief of the Journal of Rheumatology. Welcome you to the February 2026 edition of Editor's Summary. This month's in-depth interview of our highlighted paper is my interview with Ms. Natalie Davis and Dr. Jeffrey Sparks from Harvard Medical School, Boston, USA, regarding their paper titled Investigating Factors Associated with Respiratory Syncytial Virus Vaccination and Breakthrough Infection Among Patients with Systemic Autoimmune Rheumatic Diseases, and they are speaking on behalf of all the authors.
So first off, it was a pretty large sample size, 10,587 patients. And again, these are patients who were eligible for the vaccine at the time. So both had a systemic autoimmune rheumatic disease and were 60 and older. As a slight caveat, since we published our study, they did relax that eligibility criteria. So now 50 years and above is actually eligible. But at the time we did our study, it was 60 and above. Okay. And actually one of the major aims of this was just to figure out who got vaccinated. And we were debating before we got the results, certainly wasn't going to be 100%. Hopefully it wasn't going to be 0%. Was it going to be 50? Was it going to be 30? Was it going to be 5? And it ended up, we found that 10.2% were documented to have received the RSV vaccination. The caveat there being that of course, it had to be documented in our records. There is a Massachusetts vaccine registry that does allow outside vaccines to get into our system, but certainly there could have been some other people that got the vaccine that were outside of our system. However, I'm doubtful that that's going to double or triple the amount. So the 10.2% is probably the lower limit here, but overall, probably only 1 out of 10 got vaccinated, meaning a 9 out of 10 did not, or maybe it's 8 out of 10, but surely, many people did not get vaccinated. And we expected, obviously, to not have complete uptake. The second part of the study was really looking at factors associated with uptake. I think Nada would take us in more detail there. Interestingly, the major factors were related to general population factors, things like race, socioeconomic status, age, and I think Natalie will tell us more about some of the other factors. And then there were only a few breakthrough infections, meaning documented RSV vaccine infections after the vaccinations, and only 2 of those were severe.
Just to highlight a few of the factors that were associated, a flu vaccine receipt within the last year was the most strongly associated factor, and then as well as a COVID vaccine receipt within the last year. As well, patients with interstitial lung disease were also more likely to receive the RSV vaccine, and glucocorticoid users were less likely to have received the vaccine.
I hope you enjoyed listening to part of the paper investigating factors associated with respiratory syncytial virus vaccination and breakthrough infection among patients with systemic autoimmune rheumatic diseases. The complete interview is available at our website, www.jrheum.org, and on our YouTube channel. Now, moving on to the other articles in the February 2026 edition. And the first is titled Burden of Disease and Drug Response for Patients with Rheumatoid Arthritis by Shared Epitope and Anti-Citrinated Protein Antibody Status, and is by Wiffler and colleagues. The object of this study was to characterize disease burden in RA patients based on both the shared epitope and ACPA status, or ACPA status, and to determine if the response to abatacept, TNF inhibitors, and or JAK inhibitors may differ based on these 2 variables. This was done in 2 separate cohorts, and a constant observation in both cohorts was that more comorbidity burden among the ACPA negative individuals was higher than in the ACPA positive individuals. In one study, but not the other, there were additional differences with lower disease activity, lower healthcare usage, and higher DMARD usage in the shared epitope ACPA positive patients as opposed to the shared epitope negative ACPA negative individuals. In both cohorts, they found a relationship to response to abatacept treatment based on the ACPA, but not the shared epitope status. Neither of these two variables, however, predicted response to TNF inhibitors nor to JAK inhibitors. In the discussions, the authors elaborate on potential reasons for differences between the two cohorts and the therapeutic implications of their findings. The use of artificial intelligence is increasing in medicine, and in the next paper, Volden-Karovich and colleagues examine this issue in their paper titled Predicting Treatment Outcomes in Patients with Psoriatic Arthritis or Axial Spondyloarthritis, an artificial intelligence-driven approach. Using data from an ongoing, multi-center, prospective, non-interventional study in Germany, which assessed the effectiveness and safety of secukinumab in 1,965 patients with either active psoriatic arthritis or axial spondyloarthritis, they found that machine learning could define the main predictors which were associated with low disease activity and health-related quality of life. For patients with psoriatic arthritis, the main predictors of low disease activity were patients' global assessment, physician's global assessment, and prior treatment with a biologic DMARD, tender joint count, and age. A high health quality of life predictors were PSA impact of disease, Beck depression inventory, height, tender joint count, and BMI. In axial SPA, the main low disease activity predictors were the BASDI, previous treatment with a biologic DMARD, CRP, the ASES high, and height. High health-related quality of life predictors, again, were the AS high, BDI, BMI, height, and age. Secondary failure to biologic DMARDs is frequently seen in patients with systemic inflammation. Garrog and colleagues examined this issue in patients with psoriatic arthritis in the paper titled Incidence and Predictors of Secondary Failure to Biologic DMARDs in Patients with Psoriatic Arthritis. The 482 patients started on a new biologic DMARD in this single center study, 54.8% met the author's response criteria at 1 year. Of these patients who met the response criteria at 1 year, 35.6% developed secondary failure after a mean of 1.6 years from the initial response. In the multivariate modeling, high swollen joint count and PASI at baseline were associated with a secondary failure. Patients who received a TNF inhibitor versus other biologic DMARDs as the first-line biologic DMARD were less likely to experience a secondary failure and treatment initiation during the more recent calendar years. An accompanying editorial titled, "What Predicts Initial Biologic Disease-Modifying Anti-Rheumatic Drug Failure in Psoriatic Arthritis, and How Common Is It?" Dr. Peter Nash from the Griffith School of Medicine, Brisbane, Australia, reviews the importance of secondary failure to biologic DMARD and puts the findings of Cargog and co-authors into the perspective of the currently available literature. Next paper is by Hansen and colleagues and is titled "Comorbidity Development and Mortality During 10 Years of Follow-Up in Danish Nationwide Cohort of 3,178 patients with systemic lupus erythematosus." The authors used the Danish National Patient Registry of 3,178 patients who were diagnosed with SLE and compared them in follow-up to over 60,000 age and sex-matched comparators. To study these comorbidities, they used 27 selected comorbidities included in the Charleston Comorbidity Index. In patients with SLE, the highest first-year incident rate ratios were, as may be expected, for coagulopathy, renal disease, and pulmonary embolism, while renal disease, coagulopathy, and osteoporosis had the highest incident rate ratios during a 5 to 10 year follow-up period. Patients with SLE had a 4.1 times increased mortality in the first year as compared to the matched cohort, and a 1.6 to 2.1 increased mortality during each subsequent follow-up period. New therapies are required for refractory dermatomyositis. Carlisle and colleagues examined one such novel therapy in their paper titled "Anaphrolumab Therapy in Dermatomyositis: New Insights from Refractory Patients in a Small Open-Label Study." The results of this paper were encouraging, as all 4 patients with refractory dermatomyositis who were treated with anaphrolumab had a significant reduction in their skin score, increase in their muscle strength, and increase in patient global assessment with a decrease in prednisone dose. These encouraging findings suggest that anaphrolumab should be studied further in patients with dermatomyositis. Now switching to pediatric rheumatology with a paper from Tsai and colleagues for the REACH-OUT and COMPRE registries, and is titled "Effect of Treatment Changes on Health-Related Quality of Life in Canadian Children with Juvenile Idiopathic Arthritis, Results from REACH-OUT and COMPRE, Comparing How Medication Use Affected Health-Related Quality of Life in 2 different inception cohorts, one studied from 2005 to 2010, and the other from 2017 to 2023. They found that by year 1, a greater proportion of patients in the latter 2017 to 2023 cohort had used conventional or biologic DMARD as compared to the earlier cohort, while improvements in the total GAQQ score across all domains from baseline to year 1 were similar between the cohorts. Greater improvements were observed in the 2017 to 2023 cohorts in all of the domains if patients had greater than or equal to 5 active joints. In an accompanying editorial titled Changes in Modern Care of Juvenile Idiopathic Arthritis, How Much Does This Affect Health-Related Quality of Life? Ms. McKenna and Dr. Earl from the University of Manchester, United Kingdom, review the work by Tse and colleagues and highlight why changes in health-related quality of life may differ from the changes in markers of disease activity in the therapies used. Our next paper is by Malqueen and colleagues and is titled, Do Monosodium Urate Crystals Reduce at Different Rates in Joints and Tendons During Urate-Lowering Therapy? A dual energy computed tomography study. The authors examined 50 patients from 2 different clinical trials of urate-lowering therapies using serial DEC scans over a 1-year period. They found similar rates of monosodium urate crystal dissolution occurred in both between the joints and the tendons during the studies. These findings differ from prior studies reporting changes as detected by ultrasound following oral urate-lowering therapy. In the accompanying editorial titled The Reversibility of Urate Profile with Treat to Target Gout, All Gone Forever, Dr. Jasvinder Singh from Baylor College of Medicine, Houston, USA, reviews how the study by Malqueen and colleagues moves the field of gout forward and suggests further studies are required to continue to improve the care of patients with gout. The issue of interdisciplinary team-based models of rheumatology care, where rheumatologists and healthcare professionals deliver care collaboratively, is studied in our next paper is titled, It's Like a One-Step Shop, a qualitative study exploring patients' experience with interdisciplinary team-based rheumatology care, and is by Circa and colleagues. They used semi-structured interview of patients with inflammatory arthritis, inflammatory rheumatic disease, and osteoarthritis who had received interdisciplinary care. They found 5 common themes, which were educational empowerment, unhurried thoroughness, responsive care, timely care, and personalized care when multi-specialized collaboration was performed. Patients valued this one-stop model, which reduced the number of external referrals and separate appointments. The authors suggest that they finally support a wider implementation of this model of care. Our expert review this month is titled The Usual Suspects, Established and Emerging Predictor Variables for Remission in Rheumatoid Arthritis by Drs. L.A. Suave and Cheryl Barnaby from the Cummings School of Medicine, University of Calgary, Canada. The authors review the potential factors that predict the outcome of remission. The authors review the potential factors that predict remission in patients with rheumatoid arthritis and identify opportunities for improving the measurement and characterization of these factors for improved precision medicine in determining prognosis. They propose new They suggest that these new predictors could expand our understanding of factors influencing the attainment of remission, but of course, further investigation is required. We have one systematic review that is titled Clinical Features and Outcome Measures of Cross-Still Disease, bracket, systemic juvenile idiopathic arthritis and adult onset still disease, close bracket, cohorts worldwide. A systematic literature review and is by Ballet, Dustruit, and colleagues on behalf of the CARA Systemic JIA Working Party. In this systematic review, the authors reviewed 240 articles comprising more than 23,000 patients from 37 different countries with SJIA or adult onset still disease. They found that data reporting was wildly heterogeneous. There was no clear consensus on the definition of macrophage activation syndrome, and they concluded that a consensus on identification of a standardized data set for still disease cohorts is required. Our article in Panorama this month is titled Reflection Across Two Continents, a Journey Between Canada and United Arab Emirates, and is by Dr. Khalid El-Nakbi from the UAE University, Al Ain, UAE, and he reflects on his experience in rheumatology in two different healthcare systems. There is one research letter by Chan and colleagues titled Arthroplasty, Joint Histology, and Surgical Outcomes in Patients on Immune Checkpoint Inhibitors, a single-center case series. This month we have two images in rheumatology. First is titled A Rare and Severe Cutaneous Presentation of Systemic Lupus Erythematosus, which described an 18-year-old woman who had been diagnosed 1 month earlier and now presented with a 3-day history of pruritus and burning of her cheeks. Examination showed extensive rash with dusky areas and yellow crossing on her bilateral cheeks and on her chin. Over the next few days, her skin findings progressed to a full thickness skin sloughing on the face and chest, and to a lesser degree on her extremities. Mucous membranes were involved, as shown by ulceration at the vaginal introitus. A skin biopsy was consistent with toxic epidermal necrolysis like SLE. The second image is titled An Uncommon Mimic of Spondyloarthritis, and it describes a 20-year-old woman who presented with a 5-year history of increasing low back pain and hip pain. Her initial MRI showed mild bone marrow edema in the right SI joint and hyperostosis of the hip. Over time, she developed pain and swelling of multiple PIP joints, her knees, and her ankle. Radiographs of her thoracic and lumbar spine showed platyspondyle with reduced intervertebral disc spaces and kyphosis, while shoulder and knee radiographs showed osteophytes, joint space snaring with sclerosis. These findings were suggestive of progressive pseudo-rheumatoid dysplasia. Genetic analysis confirmed this diagnosis as identified 2 heterogeneous mutations in the Wnt1 inducing signaling pathway, protein 3 or WIS3, also known as the CCN6 gene. I want to thank you for listening to this podcast and encourage you to read the complete articles in the February 2026 edition of the Journal of Rheumatology. All the articles are available either in our print edition or our online edition. Latter is available at www.jroom.org. And please watch the complete interview of the authors of the highlighted article this month, and I encourage you to see previous month's interviews if you have not already done so. Two are available at our website and on our YouTube channel. If you have any comments or questions of any of the articles in this month's edition of the Journal of Rheumatology, please send them to manuscripts@jrheum.com, and please join me for next month's March 2026 edition of Editor's Summary. Thank you for listening.